All right. We are live. Hello. And welcome to the Serdentity podcast. I am thrilled this evening to have the great Dr. Scott Siegel on my podcast. So I'm a singer. So this is like if I had Bonnie Raitt on my podcast. You know, if I like met Bonnie, if I ran into her and said, "Sure, I'll be on your podcast," I'm like, so it's just it's awesome. And the Panny meeting that I met you at, I mean, of course I know who you are. Anybody that's anybody and had any exposure at all to the field of orofacial myofunctional therapy has heard of you because you do great work and you're out there and you're getting it done.
That's right. All as part of a team.
Right. And so I wanted but then the following weekend you had another conference at you're one of the founders of the International Consortium of Oral Ankylofrenula Professionals. Wowie wow. Consortium. That's a word, man.
Right.
I like it better than club.
Yeah. He was trying to come up with something a little more
the He-Man Woman Haters Club. I'm just kidding. So Serdentity, I've been talking about Serdentity is a combination of serene and dentistry. And, you know, I've been talking about dental fear for 20 years, but it wasn't until 2018 when I took my first course with Samantha Weaver in Chicago. Like in the first 15 minutes of that class, I realized, oh my gosh, it's the airway. These people can't breathe. And I knew that their behavior was a post-traumatic stress sort of reaction. And but I never could really get to the initial trauma. I mean, a lot of people can recount a bad episode, a bad appointment when they were kids usually, but it wasn't until that moment that the puzzle pieces all fell together. And dental fear is still a real thing. There's still so many people that that dread the dentist, and they don't go for that reason. And what happens is, and I'm sure you know this from experience, is they don't go for a long time, then they have a lot of disease, and they show up in the dental office, and they need all this treatment, and you know they become re-traumatized because and it's not male and it's not malicious. I know for me, I want to help people, you know, I'm a helper. And so I want to do what's right for this person, but instead the person leaves feeling ashamed and quite possibly in pain, and then they don't come back. So what I'm trying to get across to my fellow professionals is we need to approach our treatment differently. And you know, you're a physician and a dentist, and that's really the model that we need to start going toward. Did you ever do any general dentistry, or did you
no, only in school? But I'm a third generation dentist. My father was a dentist, his father, great uncle, so it's kind of in the blood. And I grew up with fears myself of being in my dad's chair. Most of them were unfounded, but like when you talk about your aha moment, you know, I had an aha moment. I've been doing tongue ties and all of this stuff for 24 years, but not focusing on airway and not understanding the impacts on airway. Probably maybe about a decade ago, my aha moment was with the American Association of Physiologic Medicine and Dentistry with Dr. Gelb and Hinden.
Yes.
When I kind of really got into the ropes of that and Dr. Boyd and understanding what the impacts of airway are on our nervous system.
Right.
And that fight or flight response that, we talk about, and kind of understanding, I need to listen to these patients a little bit more closely and understand, so that kind of switched my whole thinking about airways being the center focus of everything for, like what you were just talking about.
Right. Not only for our treatment, but to understanding, what's going on neurologically and physiologically with these patients. And a lot of times what happens is the professional will interpret this patient's behavior as rude, uncooperative. Oh, they're so hostile, and they complain about it in a Facebook group. And every time I read these rants, it makes me wonder, and I wish I had a picture. How much do you want to bet that patient had like a flat upper lip, they're a mouth breather, and they have huge tori? And is it any wonder that they don't like, that they're afraid to come to the dentist?
Mm-hmm.
And most people, I know you know this, they're mouth breathers. The vast majority of modern humans are mouth breathers.
Well, I mean, when you look at all of these pieces of a puzzle, certainly all of these things are multifactorial, but like what you said, yeah, I see it invariably myself, even from the kids, who are mouth breathing, and,
oh yes,
they have caries all over the place, and it's all this vicious cycle that we're all looking at, in our fields. Maybe it's, tough to say, we don't have the data to say, yes, this is that and this is causing that, but we see it, and we see the patterns from the kids through the adults, the kids that are extremely phobic, the adults that are extremely phobic. Many of them do fit profiles like you're talking about. So trying to make, get an understanding, and maybe to try to collect data so we can, find out further, so we can help these patients along. Like you said, most of these patients are mouth breathing. They're on that, sympathetic fight or flight sort of underlying, baseline nervous system. And, they're sitting in your chair, and the way most of us as dentists or whatnot are trained, many of them are trained to be more technicians than to sit there and understand what's going on globally with your patient.
Technology. And so I did nursing home dental hygiene for 13 years. I had patients that couldn't tell me what day it was, but they could tell me about their visit to the Eastman Dental Dispensary in 1947. So the technology back then, it's no wonder. I mean, that barbaric. Was, low speed belt driven drill, no anesthetic. So technology got better, but I wonder if because of the technology got so much better that we kind of forgot, because we had the luxury of all this technology.
Mm-hmm. I think that, certainly plays a factor in it. And, going through school and education, they're always talking to you about, understanding and listening to your patients. But the drive, like in dental school, is procedures. It's, really kind of getting your requirements done and understanding. And if you come out into a residency program, which is fast paced and whatnot, most everybody is still not spending that time, the quality time with your patient, to help them settle down and maybe try to figure out, maybe it's just not, as Kevin Boyd says, you're putting out caries fires or sugar fires all the time, but you're not understanding what the, why is this happening. Is this child a mouth breather? Are they dealing with something else going on? Is that adult, did they have a traumatic event because they were unable to brush their teeth earlier on and had a huge trauma that set them, up to be a severely dental phobic moving forward? So, trying to have an understanding of your patients and listen, and
What?
right.
So, you can expose 10 people to the same trauma. but not all of them will have a PTSD-like reaction. Something that plays into a PTSD reaction is disorganized attachment early in life. So I'm wondering if how many future dental phobics you are preventing by getting these tethered tissues taken care of so that they can nurse and they can bond. In addition to helping them with their oral health.
That's always the goal. We don't have data, but you hear the reports from the families all the time. After you do, such and such a release, their baby or the child is more calm. They seem to be breathing better. They seem to be, less tense and whatnot. So moving forward in life, maybe you're helping, like you said, and set them up for potentially better breathing, less anxiety, less of these other things. And hopefully as they're growing and developing, if they have, more functional soft tissues, that the hard tissues fall into place that way. And the jaw bones and dentition will kind of fall into place. So that's always our underlying goal. And not having true hard data to support that, I think most of us in this field see it on a daily basis.
Well, Kevin Boyd was talking about it at the PANI conference, a hypothesis.
Right.
So we have a hypothesis, and sometimes I get a little irritated with all this data and evidence, evidence-based, because, for one thing, patients don't care about empirical evidence. Patients care about anecdotal evidence. Patients care about what happened to, their wife, their husband, or some other thing. And we're always going on and on about all this research. And people are saying, well, there's not enough research. Well, but so what? I mean, you've seen this in thousands and thousands of babies. So, and Dr. Zagi did finally release a paper that, you can find it in PubMed or whatever. And, that helps get us a little closer. But, sometimes we have to just kind of go with what we know to be true.
When I talk to patients in consultation and that question comes up, either my doctor or my pediatrician said there's not enough science or research to back. It's like, well, we're seeing it there. It's emerging. But we do take into consideration the experiences of many, many people that we help. And, when we circle back to risk versus benefit and risk versus benefit ratio, it's like, well, really what we're doing, if you're talking about maybe a tongue tie release or something like that, that's a pretty low risk procedure with potential benefits. When you look at that, ratio, it's like we tend to think there's a lot more benefits. And yes, maybe there's not research that some doctors are looking for, but we're seeing it and it is emerging. And again, it's not like we're doing some sort of major, procedure that's going to potentially, certainly you can always have some sort of adverse outcome, but far and few between.
Yeah.
What we do see, vast majority, and you can go on social media to see that. You can go on people's Google reviews and see the numbers of, people that it's been life-changing for them. Whether they're babies
there's a
child.
Facebook, tongue-tied adults Facebook group.
Right.
I mean, there's people that
sharing their stories.
Yes, and they're looking into it, and mewing, the tongue up in the palate, that has all of a sudden become very trendy. And thank God.
Yep. So we're involved, we're trying to get this integrated into medical and dental education at this point. It's tough. I'm a board member of a nonprofit called the Airway Revolution Foundation. It's, TARF.org, or something. I'll give you the website. But what we're doing is we're collecting stories like you're talking about. We're having people get on there so we can have a database of stories that are positive. And the reason we have that is because we went to NIH, we went to Congress actually to find out what does it take to get, things changed in education. What does it take to get funding from NIH to help move things forward? And they said, we need stories. We need the stories of people where a procedure you have done, or maybe an expansion, myofunctional therapy, whatever it is that has improved your life from an airway standpoint to help you move forward. We need those stories and documented.
That's amazing. So yeah, I can help with that. I had my tongue released.
Right.
I had my tongue released in September of 2021. And, I'm the classic extraction, retraction, orthodontics. And so my palate is just too small. But, what I noticed was, and even my lower back, I noticed that there was less, that it was just, wow. And being a dental hygienist for 35 years, the shoulders hunch up. And I remember I was walking in the office one day and I was like, wow, my shoulders feel great. And I suffered with a lot of discomfort, a lot of pain across my shoulders and, in the back of the neck. And that was all gone.
Yep. So, again, it's a story. Many of us have these individual stories that you've gone through some sort of treatment that way that has helped you, but it's not part of mainstream, medicine or dentistry at this point. So that is our goal. And you talk about, the phobic patient. It's like so many patients like that. Yeah, they come on so much overdrive that you just trying to talk to them, and you talk about breathing. We talk about trying to help them breathe through. Then you're trying to help them breathe, but they can't breathe through their nose. They can't.
Exactly.
So we're trying to figure out, all right, so maybe there's something else going on here. Let's try to help these patients.
The nose doesn't work. The nose,
Right.
this, the nose is use it or lose it. So when you mouth breathe for years and years and years, your nose just kind of forgets. So it's not, it would be really great if all we had to do was slap a piece of tape on there and everybody would be a nose breather, but it just doesn't seem to work that way, which is why you have Buteyko and all these, breathing breath instruction. Who knew you had to teach people how to breathe? I've had tremendous success with anxious patients in breath coaching, taking a few minutes to, have them in through the nose and with all this, yoga and everything that everyone's doing, they're getting these great big deep breaths. And, that's actually not helpful. That keeps that fight or flight thing going. And carbon dioxide, has a bad rap. We need carbon dioxide. Carbon dioxide, is responsible for some, really important biological processes, but we've been taught, to breathe, get that all out of there. But as a myofunctional therapist, I've seen so many adults that if they had been released as children, their mouths would have formed differently.
Yep.
And, the modern, part of the problem with modern human life, right, is that everything is soft. You don't even have to chew. You don't even need teeth anymore. So, that just adds to the complications of trying to grow a healthy jaws in these kids. And I'm seeing more and more kids, and pediatric dental offices, they're like Disneyland. But children can still be traumatized because they can't breathe.
Right.
and there's there's links, mouth breathing, to ADHD and all these other these behavioral issues. And if we can just get these kids, you get them released, and then we get them breathing with their noses, it's a miracle. Have you ever seen Finding Connor Deegan?
Oh yeah, yep. I direct patients to that all the time. I recently had a patient. I think he's an 11-year-old patient where the mom, we had originally, they came in to me. I forget, maybe it was a friend who sent them to me. Kid had a clear tongue tie, but a lot of other things going on. So sending him, for myofunctional therapy, for expansion, and got a team involved. And we started to deal with these things, and releasing the tongue, the palate expanded, the myofunctional therapy in combination. Mother was like dumb. She was completely blown away. She's like, I can't believe that, nobody, countless medical professionals have seen this child in the, New York metropolitan area, and nobody has been able to kind of figure out what's going on. Child's been suffering from ADHD, behavioral issues, and all of these other issues with, snoring, restless sleep, fidgety, all of the things that just get labeled and then pushed off. And she was like, where can I go to, help illuminate others? And again, we're directing her towards, sharing her story, because these are how many kids are floating around out there like that?
Yeah,
that turn into adults that are struggling,
right,
and they
with
can't sit in a dental
anxiety,
chair.
depression, yes, substance abuse. So if your mind is always whirling there, it's natural to want to seek some way to bring that down. And that can lead to substance abuse. And kids nowadays, they can go to a 7-Eleven on the corner and get a Rockstar energy drink. And I call them training wheels for addiction, because this kid learns that, wow, if I drink this stuff, I feel different.
Right.
And sometimes substance abuse isn't even about feeling better, it's just different.
Yeah.
So, anything is better than the way I feel right now. I need to feel different. When you're talking about labeling, that is part of the problem too, I think, with these fearful patients that act out. They get a label, right? They get labeled a PETA, or this or that, the other thing. And I've had the experience of work, like subbing in an office for a day, and I'll see this patient and they'll pull me aside. Oh, she's the worst patient in our practice. Oh, she's awful. And I work with these people, and they come out to the desk all smiling, and the office staff is like, what did you do? And I approach, maybe it's easier when you are not familiar with an office, to just be able to walk in and approach every single patient with this non-judgmental, and it's a calm, pleasant feeling. And I had to work to cultivate that for a long time, and I absolutely did not have that in the early years of my career. And what I found is that even though I would be nice to people, I would be so burned out. You hear about burnout now all the time. And by the end of the day, I would be so frustrated, I would be in tears. And I'm like, there's got to be a better way.
Yeah,
got to be a better way to do this. What do you think?
100%. It's I think those of us who are paying attention to this, we're all kind of in the same sphere of thinking the same way about how to listen to your patients, to be calming and not just treat them like a tongue, or treat them, as far as a procedure, is concerned. So I have found, great success in my ability to listen. Part of that I got from my father, who was very much like that and gentle. And you'd hear from his patients, just, if you could be like your dad and just listen, people will keep coming. So you just listen without just jumping to something. But as you're listening, and I had a professor once in school say, just listen to your patient. They're trying to tell you the diagnosis. So it's very easy to pick up when somebody's dealing with an airway issue because of, what they're telling you, their habits, their, daily habits, whatever sleep habits you can get if you have a there to talk about that. So, there's so many little red flags that you can pick up on just by having a routine conversation.
Right. And when you're updating the medical history, patients who are mouth breathers, who have sleep apnea, 9 times out of 10, they're on metformin, they're on some sort of blood sugar medicine, high blood pressure. These things are all in that, it's sort of like a syndrome, right? This airway.
Yep.
Even if they don't have sleep apnea, they definitely, have the upper airway resistance. And, that just helps the person, the professional to clue in. And I didn't know, you don't know it till you know it. And once you know it, you can't not know it.
Exactly.
When I see a patient out in, well, now I see them everywhere, not just in the dental office. Like, all these people, they have no chin, their upper lip is flat. And we were watching Game of Thrones, and I'm like, oh, Sansa's a mouth breather.
Yeah, you wind up picking all those things apart very quickly. Yeah.
And sometimes you can really hear people breathing, like on the soundtrack. Now it's annoying to me. Like, I guess we're supposed to get the idea that this person's, undergoing some stress, but it's like, really, like, close your mouth, please. So I just wanted to, we've been on about a half an hour, which I think is, the modern human, time, attention span. And I can't tell you how thrilled I am to have you on here with me today. And
my pleasure.
To be, and this is what we need to do. We need to talk to each other.
Yep.
And reach out to each other. And, Dave McCarty talks about silos.
Right.
We got to get out of those silos.
Yep.
And I actually have a lot of hope for future dentists, because I do think that as the airway comes into the dental sphere, that we're going to see, already saliva testing exists that can find genetic markers. Right. So we're going to be able to do so much more for our patients than just drill, fill, and bill.
Right. I think you have, that exact thing. You feel more like a doctor or a physician of the airway and mouth that way, where you have that ability to help diagnose and treat and change and enhance people's lives that way. I've seen more excitement coming out from dental students that we've come across, or even young residents, either general or pediatric dental residents, even oral surgery residents that I've helped train, and they start to, it's like you see the light bulb go off. It's like, wow.
Isn't that so great? It's so exciting.
How come we're not taught about this?
Oh my God! In dental hygiene school, it was about the teeth, and it was about tartar.
Right.
Get that tartar off. And as a hygienist, I think sometimes we just get that tunnel vision, like, see tartar, must scale.
Yep.
I have a lot of hope for this GBT, guided biofilm therapy, which is a whole new way to approach, the biome. We need to change the biome. Yep. It's not about, bugs on your teeth. And So yeah, I have a lot of hope for our profession going forward, and you know, doctors like you are part of it, and I'm eternally grateful to you for finding a few minutes to chat with me today. And
My pleasure, and anytime, and it's love talking about this stuff. Like when I get up to talk, I don't say I'm lecturing. I'm here to talk and discuss and just share experiences.
Well, if you ever want me to come and talk to anybody, I would love to talk to them about roots of dental trauma. And you know, I cover all this in my talk, and I actually also speak about, you know, how are we taking care of ourselves? You know, if I'm exhausted, right, and I'm this, you know, if I'm a codependent healthcare provider, right, who is seeking to fill some sort of internal need by helping other people, and they're not responding the way I think they should, I'm going to get very frustrated. So, you know, I talk about that too. And obviously I love to talk, so that's not a problem.
Me too.
So you have a beautiful night, and
Thank you, Beth. You too.
I will look forward to speaking with you again.
Sounds great.
All right. Thanks a lot.
Stay safe. Bye-bye.
You too. Bye-bye.